Hello, everyone. Good evening, good morning, good afternoon from wherever you are joining us in the world. My name is Colleen O'Connell, and I'm a rehabilitation physician from Canada, currently in Ukraine, and I am the chair of the International Spinal Cord Society Emergencies Subcommittee. So it is my big pleasure to introduce to you today our panel. Myself and my colleague Joe Armstrong, who is a physiotherapist from Stokeville, Mandeville, who has worked in a number of areas in the world in conflict and is a member of our ISCOS Emergencies Committee. We will help field the questions. Dr. Aladdin Elmak will be starting. He is in Australia and from Sudan and has a lot of international experience, and he is a rehabilitation physician. Firas Sarhan from Palestine, who is a spinal cord injury nurse and the head of an education program for spinal cord injury, will be then speaking. And lastly, by Eric Wertz from Humanity and Inclusion and the ISCOS Emergencies Committee will speak on the therapy roles. He is a rehabilitation specialist. And so with that, now I will invite my colleague, Dr. Malik, who will share his screen.
Thank you so much, Colleen. Thanks, everyone, for attending today. And thanks to the World Physiotherapy and WHO. I had the pleasure of presenting today an overview of spinal cord injury in conflict setting, whether man-made conflict or a natural disaster. As Colleen said, I work at Royal Melbourne Hospital, but originally I'm from Sudan. So I think what we need to understand is general principles for emergency intervention and spinal cord injury care. Usually, extrication in challenging environment, triage first care with limited resources, and surgical and medical attention can be questions as well. Early functional rehabilitation is always recommended. Psychosocial support for patient and family, and planning long-term reintegration into the community, in back to work and back to society. And part of it will also define a teaching expert group. The minimum technical standards of the WHO key initiatives assess each trauma patient for spinal cord injury and handle and transfer a patient appropriately to avoid secondary complications. So how we examine the patient, how we log roll, how we re-examine the patient, we always try to make sure that it's our attempt to avoid secondary complications. Ensure appropriate examination, and provide analgesia, and ensure immobilization of the spine, because we don't want any further damage to the spine. Also, especially in limited resources countries, avoid prolonged period sitting or lying on hard transfer boards to prevent skin issues or pressure ulcers. Ensure continence, blood and bowel care, as I said, skin care as well, and transfer patients with suspected spinal cord injury to facility with the ability to definitely manage their injury. So we always try to transfer them to a specialized or an area where they can get spinal care. And we follow the guidelines from the Ministry of Health and with suspected injury. We also, all of us, from all the disciplines engaged in patient care, we need to ensure the continuum of care. So from the door of emergency department or from the scene to emergency to the acute ward to rehabilitation and back to the community. The cohort is for this recommended practice is identified patient with designated spinal cord injury, sites with family support, initiate training, mentoring in under-resourced country or region for short and long-term goals, and foster coordination of care between stakeholder for an emergency and long-term management. So the teams that looking after the patient, they need to be able to talk to each other, integrate with each other to provide the best care for the patient. Ensure the patient carries their, always whenever they go, they have this identification as patient of a spinal cord injury, so they can receive the care they need. Um, of course, in normal setting or usual setting is different from an austere conflict reality. So evacuation can be different. So in normal setting or in well-developed countries, usually evacuation can be immediate and rapid, or helicopter ambulance within the golden hour. In conflict area or conflict zones, sometimes that can be a problem, and there can be in stretchers, can be hardboard, and the facility in ideal high income countries specialized, but over there will be like overwhelmed type 1 or 2 hospitals. Sometimes they don't have CT or MR. Surgery will be provided on the spot if required or indicated in high income countries. However, there will be delay or sometimes doesn't exist in the conflict area. Discharge usually is coordinated discharge to make sure that the patient is safely and appropriately integrated into the community in high-income countries. However, always they go to refugee camp or go to tent or go to relatives in a conflict area. So there is a huge difference between the two. Mechanism of injury, the in the context is different. So in usually, in blunt or crash trauma, earthquake or building collapse or blast, often cause close or high unstable fracture, high risk of secondary injuries, and in penetrating trauma, active combat gunshot, machete attack, often contaminated with high infection and also it can go beyond the point of injury as well. The clinical profile also is different. Additional high probability of associated case abdominal pelvis or long bone, and in the penetrating trauma, usually as there is high risk of associated vascular or visceral injury, depending on the trajectory of the bullet or the gunshot. Early acute care is very important. As I said, golden hours is we always need to try to catch these golden hours. Requires ABCDE protocol. So airway, maintain airway while applying a strict manual inline stabilization. We don't use fracture on children in low resource setting. Breathing, we always check for breathing, ensure that breathing is maintained. We check for circulation and make sure that circulation is intact as well. C is stand for catastrophic hemorrhage. Severe peripheral hemorrhage is the primary lethal, usually injury in arm conflict. Tourniquet and package precede spine care in this setting. What you need to do, you need to assess what? Assess the pulse, circulation, sensation, check all the sensation, all the body, go from top to bottom, and check the strength. And we'll come later and speak about the key muscles, how to check the strength. So the strength of the muscle, you grade them 0 to 5, and quickly do that without causing any further damage to the spine. The main type of spinal cord injury, and according to the classification, complete spinal cord injury or incomplete. Complete means what? Means there is a complete intersection or complete cut of the spinal cord. So there will be interruption of the spinal, or sorry, of the impulses coming from the brain or any area above the level of injury to below the injury. However, in incomplete, there will be a pathway where there'll be some impulses or connection between the two parts, the brain and above the injury and the below the injury. Um, if we go back to anatomy of the spinal cord injury, as we can see here, so we have the cervical, the eight cervical dermatomes, and also we have the thoracic, or sometimes we call it the dorsal, and we have the lumbar and the sacral. So each area of this is responsible for supplying neural supply to certain organ or certain muscles in the body. And if we talk about the main muscles, so the key muscles, so these are, the elbow flexors, right wrist extensors, elbow extensors, and finger flexors, and on the lower limb, the hip flexors and knee extensors. These are very important in helping us to classify the spinal cord injury. If the injury at the cervical level usually lead to tetraplegia. So tetraplegia depends if it's a high spinal or low spinal, because if it's low spinal, it can spare some uh, of the movement, sometimes in the or wrist, or sometimes in the upper chest. The thoracic region usually result in paraplegia. Paraplegia means paralysis of the both lower limbs and lumbar as well. Sacral can lead to other injuries, which we can talk about later. This is another image showing the difference between complete and incomplete. So if you can see here, the one on the right side of the viewer or on the left side of the screen, it can show that there is some passage of the impulses or part of the neurons passing the point of the damage. That's in incomplete spinal cord injury. If you have a high cervical injury, what are the organs that involved? As we know that the supply of this organ of breathing, whether the chest or the intercostal muscles or the diaphragm, usually come from the neck. So we have the phrenic nerve from the neck, and also the intercostal muscles, the lower intercostal muscles that all control the breathing. The cardiovascular system coming from the neck as well, or coming from the brainstem. And a patient with high cervical injury can also suffer from impaired urinary and bowel function, and also can affect their ability to walk and sensation as well. If you go down lower spinal cervical injuries can also affect all these, but it will be to a lower degree. If you see here in this picture here on the upper corner, right corner, so lower cervical injury can result in tetraplegia or quadriplegia or paraplegia. A thoracic injury usually cause a slightly, not mild, but slightly breathing problem and muscle weakness and also blood and bowel. Lumbar injuries usually cause muscle weakness, impaired urinary and bowel function. So the ISNCSI, so the International Standards of Neurological Classification Spinal Cord Injury Assessment. So three fields: sensory examination, usually we use pinprick or light touch; motor examination, the 10 key muscles I mentioned before; and the clinical indicator usually tests for anal pressure and voluntary anal contraction and sensation. This will help you in differentiating between complete and incomplete. If the anal contraction is preserved and there is sensation, then that signify incomplete injury. If it's absent, then that's probably a complete spinal cord injury. The sensory examination and motor examination will help you in defining the level of the injury. This is the Asia sheet, the international standard for neurological classification spinal cord injury. And if you can see here, these are the key muscles in the upper limb and the key muscles in the lower limb. And this is, from C2, C3, C4, and going down to S4, S5. This is you test the sensation in both sides, on the right and left. And then you record this, and this will help you in coming up with a diagnosis. I mentioned this. So imaging is very important in confirming the injury. Usually, you can obtain an X-ray, but the definite radiological diagnostic tool is MRI or high definition CT scan if MRI is not available. So if you can see here in the X-ray, can show you there is disruption of the vertebral column, cannot show you the spine. But when you do a CT scan, you can show you there is, for example, like this picture here, a fracture in the vertebrae. And if you look at the spinal cord here, there is a damage of the spinal cord. So that corresponds with this vertebral damage as well. Mhm. So MRI is the gold standard here. As I said, thin cut CT scan can be and should be used to evaluate abnormal suspicious area. And typically the craniocervical or cervical thoracic junction tract can be shown. If you don't have an MRI, but you have a plain film and CT scan, that can provide you with false negative rate of less than 1%. So highly useful. Okay. So there is a concept we call neurogenic shock. So due to disruption of the sympathetic output to the heart and uh, the peripheral vasculature, and that different from the vascular shock. So I'll speak more about that. And neurogenic shock occur because of there is a huge influx of unopposed parasympathetic response and blood pressure, affect the blood pressure and heart rate. In neurogenic shock, blood pressure will be reduced and will have bradycardia. Patient will have difficulty breathing, and the skin will be warm and dry, and because of the injury, will have weakness and paralysis and absent reflexes. The difference between neurogenic shock and hypovolemic shock. So the etiology of neurogenic shock is loss of lack of sympathetic outflow, and in hypovolemic shock, the problem is loss of blood. Blood pressure in neurogenic shock will be low. Blood pressure in hypovolemic shock will be low as well. However, the heart rate in neurogenic shock will be low, but in hypovolemic shock will be high in an attempt to push more blood to the area that's affected by the loss of blood. The skin in neurogenic shock will be warm, but in hypovolemic shock will be cold because there will be drainage or movement from the blood from the skin and subcutaneous area going to the supply and feed the essential organs. Urine output will be normal, but in hypovolemic shock will be low because of the internal movement of the blood. The mean blood pressure in will be, sorry, this one minute. The mean blood pressure greater than 85, systolic will be higher than 90. So and our understanding in spinal cord injury usually will have a low blood pressure, and so that we should be aware of that. And use of vasopressor, and but we need always to avoid fluid overload. So not to attempt to correct the blood pressure by giving fluid because that can lead to fluid overload. In a limited resources country or in conflict area, so surgical management needs to be sterile or experienced spinal surgeon and indication close fracture, but that all is not available, or if it's available, will be delayed. So non-operative management, high nurse to patient ratio, which is sometimes is not possible, but that's required, and indication for the penetrating trauma. And penetrating trauma in conflict area usually carry a risk of contamination and infection. So usually there will be an accompanying infection of the wound or injury. We always need to emphasize wound management, debridement, and skincare. And sometimes or most times we give antibiotics and prolong immobilization. However, if without a trained spinal surgeon or CT or sterile operation theater, surgery causes more harm. So yes, we need to be aware of that. So, how we look after these patients in an operative ward care is hemodynamic stability. Try to maintain the mean arterial blood pressure around 85 for 7 days of injury to ensure the perfusion of the spine and maintain growth. So, whenever the patient we need to tend, we need to have 5 people there to safely tend the patient in a certain way. And strict mobilization up to 12 weeks bed rest, and traction can be used as well. And to care for the skin or to prevent skin injuries, 2 hourly tents is usually employed. Pressure injury usually occur as chronic prominence. We need to be aware of the secondary complications. Usually, secondary complication in these people who are not able to move by themselves, or and sometimes have problem breathing, coughing, and blood and bowel problem. Usually, lung, respiratory failure, or infection in the lung, skin, pressure ulcers, pressure injury, blood and bowel sepsis, high risk of infection in the urine UTI, and impaction in the bowel as well. So DVT is also common there. So we always need to use BTE or DVT prophylaxis where available. Sometimes we may use mechanical prophylaxis as well. There is other complications like autonomic disorders. Autonomic dysfunction in spinal cord injury refer to disruption of the regulation of body function by autonomic nervous system. And from our knowledge of the of the nervous system, we know the autonomic nervous system runs from there is ganglions and the nerves coming from spinal cord. So if there is any disruption of spinal cord, there will be disruption of the autonomic nervous system. So and we're going to talk about autonomic dysreflexia, which is a very common complication of spinal cord injury. Ventilator support can be in many ways. Mouthpiece ventilation, or CPAP, BiPAP, or tracheostomy. And this is a picture down the mask and the endotracheal intubation and tracheostomy. We need always to make sure that there is airway clearance. So if anyone, especially cervical and upper thoracic, they have respiratory muscle weakness, they are at risk of secretion retention, airway secretion retention, aspiration, and respiratory failure. So we need to help in clearing these secretions. Poor clearance of this secretion increase anxiety, stress, and reduce quality of life by on top of the increasing the risk of infection. Um, so non-invasive or even invasive ventilation already used. So airway clearance technique may reduce the likelihood of spastic complications emission. So we're going to talk about chest physio maneuver and also use of these non-invasive technique. Big cuff flow less than 270 liters per minute indicate need for airway clearance. So if the big flow at any time measure less than 270 liters per minute, this means there is indication for airway clearance strategies. Autonomic dysreflexia. So anyone with lesion from T6 or above, sometimes lower, but mostly and T6, the thoracic vertebra number 6 and above, vulnerable or at risk of developing autonomic dysreflexia. So what will happen is uncontrolled sympathetic response to a trigger, which is a physiological stimuli below the liver injury, such as either blood distension or constipation or pressure injury or skin injury. Sometimes can cause this sympathetic response and can lead to what we call autonomic dysreflexia. It needs to be identified and managed as an emergency. So it is an emergency. So if it's continued unmanaged, it can result in stroke or can lead to myocardial infarction and death. Is commonly in both acute phase. As I said before, usually the blood pressure of the spinal cord injury patient lie between 90 to 110. So if we see the blood pressure around 110, we should not regard that as a low blood pressure, and it's high for these spinal cord injury patients. So autonomic dysreflexia need an immediate attention, and I will talk about the steps that we need to do. So what are the signs? High blood pressure, bradycardia, flushed skin, and patient complain of headache, congestion in the nose. Sometimes they may vomit or feeling unwell. Number one, position. So we need to sit the patient up. We need to position the patient upright. Then remove all the tight clothing or any constricting objects, and then monitor heart rate and blood pressure every 2 to 5 minutes. Identify and remove triggers. So check for urine problem, bowel problem, skin, and check for infection. If the episode is not caused by change in the bladder bowel function, they need to do a full physical, or sometimes ingrown toenails can cause that. Pain is common in spinal cord injury. Two types of pain: nociceptive, neuropathic. Nociceptive, as you know, tissue damage. So pain caused from injury to the tissue is muscle or bone skin. Neuropathic pain from damage or dysfunction of the nerve, and usually burning sensation. How we treat pain, we use non-pharmacological measures, but like positioning, splinting, or maintaining range of movement. And then we use the WHO pyramid of analgesia. We use simple analgesia first, and then we can go to a specific or specialized analgesia such as gabapentin or pregabalin. And baclofen can be used if the pain is associated with spasticity. Some patients, spinal cord injury, especially cervical spinal cord injury, they can have problems with communication, so unable to speak. And if they're not able to speak, it doesn't mean that they have nothing to say, but we should always assess communication, and we should always look at their ability to communicate, and we should always establish a system for communication with the patient, whether yes or no, or gesture communication. And if they have tracheostomy, they can have a speaking valve. So we should always try to get a way to communicate with the patient, and the speech language and communication specialists. They are specialized in that, and they can help us identify and train our staff to how to communicate with the patient, and also put some communication guidelines there for each patient. Uh, E-transport also another source or another tool of communication. Nutrition swallowing is very important to ensure that the patient nutrition status is optimum, because that will aid recovery and wound prevention, wound healing, and also give them nutrients to carry on with their physical exercise. If the patient have a problem with swallowing, or a risk of swallowing, so they can be at risk of developing aspiration pneumonia, which can cause malnutrition, which also reduce their quality of life. Dysphagia should be assessed on admission, and there is tools to assess and screen for dysphagia. However, whenever the patient want to eat or drink, we should always maintain upright position, reduce distraction, make sure that the patient is just focusing on one task to do, which is swallowing, and swallow one by one and slowly, and make sure that he swallowed and then he takes the second drink or eating. So early rehabilitation is important, and early rehabilitation is essential for recovery, and essential to make sure that the patient regain most or all of the functions that he or she lost. Um, Initially in the ICU, still there is room for physical rehabilitation, which by maintaining the range of movement, and also chest and respiratory exercise, that is important, and maintaining the range of movement, but also reducing tightness and spasticity. In the subacute mobilization, gradual elevation using field table, strict blood pressure monitoring to manage orthostatic, introduction of abdominal binder. So if the patient having problem with dizziness or lightheaded or low blood pressure, we can use abdominal binders. In the ward, transfer training using slide board, wheelchair skills, training in the wheelchair, how to use the wheelchair, how to maneuver the wheelchair, how to master the wheelchair. So it's very important for spinal cord injury patients that to give them access, and also give them safe access to their house, and access to the community. And that will involve upper limb exercise, upper limb strengthening, and also functional recovery in managing activity of daily living. If usually patient, will have this trauma to themselves, but also the big trauma that happened to their place where they have this conflict, or to their family or loved ones, and so that can cause a psychological trauma as well. Uh, Psychologists, are important in providing this care. However, if they're not available, so you always employ active listening to the patient, validate their grief, explain their injury, provide, there is hope, but also you need to be realistic about expectation, and avoid, blaming or pathologizing acute stress. The most effective intervention is bring someone who has similar injury. So peer support is important here. So to visit the place or to talk to them, that's important. So I stop here. Thank you.
Excellent, thank you. So now we're going to bring up Firas is going to speak now. So I need to share my screen. I will bring up the slides. Okay. And Firas Sarhan, our nursing expert, will go from here.
Thank you very much indeed. Thank you for the World Physiotherapy Organization and for ISCUS and for the World Health Organization for giving us the opportunity to share our experience and knowledge with others across the Middle East and beyond. My session is going to be speaking about spinal cord injury in terms of nursing management. Really, this is a key focus will be of this presentation. Some of the areas probably will be a repeat of what's mentioned earlier on in the first presentation, but I'll try and look at it from a nursing perspective. Nursing patient spinal cord injury is quite a complex area, which is require quite a holistic approach to nursing and to care, and looking at the individual's system in terms of their bladder, their bowel, their aging, and managing pain and sexuality and other issues, specifically to spinal cord injury complications. Next, please. One of the nurses' role would be is to assist medical staff and other therapists in terms of carrying out the international standards for neurological classification and really looking at the sensory and motor testing and examination following injury, really to establish and determine the type of injury and the spinal cord injury syndromes that spinal cord injury will be individual will be experiencing in terms of classification as well, whether this is an AJA or B or C or D or an E. And again, also, next please, and that will give us the, in terms of determine also whether our patient is complete or incomplete injury. And the only way that that could be established is by medical examination of the rectally in terms of looking at the, if there is involuntarily contractions, I mean, of the actual anal passage or anal sphincters as the digit is going through it for examination. And that this is the only way that we can establish whether our patient is complete or incomplete. Next, please. Now we have so many syndromes or so many in terms of really that is based on the injury mechanism and into the whether this is a hyperflexion or hyperextension or a burst fracture or a compression fracture, and all really depending on which area of the spine is being spinal cord is being damaged, and also each one will have a different clinical presentation. And the key focus really for us is to know exactly what type of injury, what sort of syndrome, because that as nurses that will help us extremely in terms of planning the rehabilitation pathway and the rehabilitation care of that individual, because each syndrome will come to us with a complete different clinical presentation. And this slides you'll be able to have other extreme detailed information that you can look at within your time. Next, please. Also, one of the key things that we need to be focusing on is log rolling. Log rolling is quite important within the nursing process in terms of really trying to have a safe transfer of your patient, safe maneuver of your patient, and that really to prevent any further complications and any further deterioration of their medical neurological condition or neurological levels. I have two videos here which you can watch and you can really examine and see exactly how these log rolls being performed. But the key thing is immobilization of your spine, stabilization of your spine, avoid to sit your patient up or avoid your patient to twist your patient, because that could cause further deterioration and damage to their spine. Next, please. One of the key things is about the neurological bowel. The neurological bowel is one of the key problems and key complications of spinal cord injury, and that's really because due to the loss of the sort of nerve control onto the anal sphincters, the internal and the external sphincters. And there's two, sorry, two types of neurological bowels. Is if your injury is L1 or T12 and above, that means you'll have a reflexic bladder, sorry, bowel, and if you have T12 or L1 below that will have a flaccid bowel, and that really both will have a complete two different management and two different implications into the individual life. And the key thing really to focus here is you need to maintain a quality of life for that individual, as well as preventing any complications such as constipation or fecal incontinence. Next, please. Now, with a flexic bowel is you need to be establishing a routine, you need to be establishing a regime for the bowel management, and that usually starts 12 hours or 8 hours before the time of bowel evacuation, and basically by giving sort of laxatives to soften the stool, and also by inserting a couple of glycerin suppositories, and really, and that by basically we are using the remaining of the reflexes within the sphincters to allow that emptying of the bowel. And again, you need to be looking at maintaining possibly type 4 of the Bristol stool if that's possible. Next, please. And this is really the reflexive bowel management, the flow chart we actually use within the National Spinal Center at Stoke Mandeville Hospital. As I mentioned earlier on, you need to stimulate the gastrocolic reflex, and that really by giving your patient drink, mainly a hot drink, sort of 20 to 30 minutes before you starting your bowel evacuation and digital examination. And that's really that could be established a regime either daily or every other day, really depending on the patient's eating habits and the patient's social life and social interaction. Next, please. The same thing with the flaccid bowels is there is more risk of in terms of the losing of the anal tone, and that basically means that the risk of incontinence is extremely much more higher, and also there is more complications in terms of possibly um, prolapsing of the anal passage, the formation of hemorrhoids, formation of anal tears. I mean, as a result of these, could be constipation or could be fecal incontinent. And the key thing would be for you is to really try and maintain as much as possible foamed stool, which is type 3 within the Bristol scale. Next, please. To a point, you know, what I mean, here this key important thing to mention is not to insert any suppositories, because we are basically there is no reflex in terms of the sphincter. It's not remaining; it's absent, and therefore the purpose of the suppositories by giving it is really trying to stimulate the sphincter. Within this case, this will be pointless. And again, you'd follow nearly the same process in terms of applying the gastrocolic reflex by giving fluids or food, warm food before 20 to 30 minutes before the digital removal of feces. And again, you need to establish that regime with this individual, whether that will be on daily basis or every other day. Next, please. And again, as we mentioned, there is no need for use of suppositories within this type of bowel management. And the same thing applies for the bladder. The bladder, if your injury is T12 or L1 and below, that will be a flaccid bladder or a reflexic bladder, which means that the bladder the sphincters will lose the tone, as well as the bladder. And again, if we need to looking at the early phase of spinal cord injury management, we need to ensure that we're inserting a urethral catheter until the patient is recovering from a spinal shock, and that could be within days post spinal injury. And again, once the patient start recovering from the spinal shock, you would apply a flip flow, and that basically you are allowing the bladder to act and to function as a reservoir of urine. And again, once the patient is being recovering from the spinal shock and going back into long-term management, then there'll be an option there for the patient to use based on their social life, based on their hand function. And again, you need to carry out a urodynamic to establish the pressures within the bladder and the kidneys before you go into long-term management. Things you might be considering for bladder management, things like urethral catheter or suprapubic catheter or self-intermittent catheterization. So these are the most common sort of methods for managing the bladder following spinal cord injury. Next, please. Um, and the key thing really of the bladder management need to ensure that you are avoiding retention, maintaining capacity and maintaining the storage of the actual bladder itself, avoiding continence and avoid complications and keeping the patient safe. And these type of complications, things like renal calculi or reflux of the urine from the bladder back into the actual kidneys that could cause that damage. Next. And again, with the flaccid bladder, as we mentioned, is sometimes the individual could pass urine spontaneously, but as a result, we need to ensure that the patients, in terms of the residual, is below 100 ml within the bladder itself. And again, for the bladder itself, is quite important to ensure that we are turning our patient regularly, especially if they're having urethral catheter, to prevent the formation of sediments within the base of the bladder, and also to avoid the formation of that eggshell shape, around the actual catheter balloon. By doing this 3 hourly turns, I think it's quite important for the patient. Next, please. Next, please. And the other key problem and key issue is skin, and skin is really quite important in terms of the acute phase and the long-term complication, and sort of prevention. I think you need to, as a nurse, you need to constantly be thinking, stop and think skin and skin and skin in terms of assessing the skin, looking if there's any red marks, ensuring that the skin is quite nice and dry, there is no moisture, your patient is not incontinent, and your patient is really being sort of turned every 3 hours, and each turn they are doing in your patient, that you are examining and checking the skin thoroughly for any red marks, whether it's blanching or non-blanching, because this is quite important. And if the patient having any sign of red mark within their either sacrum or heel or occiput, it is quite important that we keep them in bed rest till this actually marks is out of the way. And again, you need to ask yourself and seek help from other tissue viability nurses or from the medic. And also, are we using the right mattress to prevent pressure ulcer formation? Next, please. These real examples recently that we nursed, and we looked after individual with these type of really severe pressure ulcers. And again, having a pressure ulcer mean that the patient is going to be delayed in terms of starting their rehabilitation program, and that delay could be up to 6 months, if not more. The chance of developing septicemia is extremely high, and also developing other complications linked to bed rest that could be possible with these type of complications or pressure ulcers. Next, please. And again, foot care is extremely essential for spinal cord injury because of the dryness of the tissue and the skin. In terms of nail care, is quite essential, and really to keep an eye and to observe this, and the way to do it, you can moist the feet and remove all of this dry skin. And if you do that on regular basis, we won't see these type of nails or feet for our patients. Next. Again, there is a lot of complications associated with the spinal cord injury, and in terms of, as mentioned earlier on, that C345 keep your diaphragm alive. So any injury above the C3 that will have an airway compromise and possibly respiratory failure, that your patient might require ventilation, or even below that level, sometimes the loss of intercostal muscles and abdominal muscles also could affect the breathing, and therefore the formulation of secretions. And therefore, as nurses, it's quite important you turn your patient 3 hourly to allow movement of secretions and postural drainage of secretion. That's quite essential. And assessing airway entry to both lung also essential. Measuring your patient oxygen saturation, and also it's important to determine whether your patient require oxygen therapy or any further treatment. Next, please. Again, as mentioned earlier on, one of the key complications of spinal cord injury is autonomic dysreflexia, and if it's your injury T6 and above, you'll be at risk of developing a pressure, of autonomic dysreflexia, and that's really due to the lack of communication between the sympathetic and the parasympathetic systems. And again, the key cause of of dysreflexia is bladder followed by bowels or ingrowing toenails or pressure ulcers or any infection. Within this slide, you can review within your own time, and which looks at the way you can manage autonomic dysreflexia. And again, you could do it in terms of sitting your patient upright, examining their bladder, bowels, and if there is no causes there and if that continue to happen, then you can go into pharmaceutical treatment in terms of offering 5 to 10 milligrams of sublingual nifedipine. Next, please. Again, patient with spinal cord injury, the acute phase and long term as well, that risk of developing deep vein thrombosis due to the vasodilation below the level of injury, and that's really basically the pooling of the blood within the lower veins, and the circulation will be affected. And then you need to be looking at ways of whether you need to be starting your patient in short-term or long-term anticoagulation and applying of TID stockings and other type of measures to prevent DVT. Next, please. Also, the first or the initial mobilization of spinal cord injury patient, they could have orthostatic hypotension, and the way to tackle this or address this is by allowing the patient to be in a sitting up position or within the bed at least 20 to 30 minutes before them being mobilized, applying to the stockings, abdominal binder, and you might use, some sort of medication to help the sort of vasoconstriction below the level of injury to ensure that their blood pressure won't drop. Next, please. Again, this presentation so far focused clearly on the physical side of spinal cord injury, but again, we need to think of the emotions that comes with spinal cord injury. Spinal cord injury is a complex injury that leaves the individual with a devastating consequence, and that really requires sort of us allow time for this patient to understand their injury, educate them about their injury and the consequence of it, and then offer help and support through the use of our psychologist or psychiatrist, as required and as needed. Next, please. Again, these are the type of complications that spinal cord injury individuals would have. Some of them being highlighted earlier on, others you can review in terms of musculoskeletal system. They're at risk of being osteoporotic, fractures. They could have complications of spasticity. Also, they could have a sort of neuropathic pain, gastrointestinal problems in terms of the occasional development of acute abdominal constipation or fecal impactions. So these are things that you need to be aware of, especially if you're doing a follow-up plan for your patients. And again, here we follow it every 6 months, and then annually they could come and visit our clinic or outpatient clinic. They have free telephone access. They can contact our staff for support or refer them to their local hospitals or to their GP for further support and management if needed.
Thank you, Faraz. And now Eric is going to, I'll stop share and Eric is going to take on and start sharing. And then Eric, you'll keep your slides on to the end and Joe will go over the location for the resources at the end of
Yes.
your deck. Thanks.
So I'm gonna to share. Here. So here we go. Yes. So I will. Can everybody see my screen? Yes. Yes.
No, not yet, Eric. I think share the presentation, not your screen. Yeah.
Oh, sorry. Yeah. Sorry. No, then I don't have it. Oops. I'm sorry.
Eric, would it help if one of us shared it, if Colleen shares it?
Yes, I think so, because
Okay.
I got it on my screen, but I could not get it on the Zoom. Yeah.
Colleen,
So
are you happy to go back to sharing?
Yeah, just give me
yes, just on the slide where Firas ended, in fact. Yeah.
yeah, just give me 1 second here.
Yes, after this after this one. Yeah. Okay, so my talk here, I will try in the last 15 minutes to explain a bit essential therapy considerations for spinal cord injury, but then more in a context where the environment is austere and probably where the professionals or the rehab workforce will not be surrounded by high technology, or is more working at community level or in displacement centers than a rehabilitation center. Next slide. So I think that the former speakers talked already about the different resources that you can consult, but of course I will review them again, and they will be again reminded, I think, at the end of this presentation, but just a slide to make you again familiar with them and not forgetting them. Next. Now, in terms of different levels of injury that were explained by the former speakers, I will talk more about main advices that you can encounter according to these different levels of injury. The first one is, of course, the high lesions where there is not much function or mobility remaining in the injury of the spinal cord injury, but where the focus should be on pertaining the cardiovascular status of that patient, mainly his respiratory capacity. And for this, there are specific exercise possibilities for tetraplegics at C4 or C5, where the excretions need to be managed with active exercise, respiratory exercises, either with a bubble bottle or with an incentive spirometry. Next. Of course, what is also important is that there will be a very heavy muscle imbalance at that level of injury that needs to be worked on, and where retractions and flexion needs to be managed with positioning or stretching exercises on one hand, and of course the remaining force in terms of extension needs to be reinforced with with possible exercises and a therapy approach. Next. The positioning here is very important, knowing that in the settings where we will see these persons, we will need specific equipment that I will go further on. But these specific bad positionings need to work on how, probably here you can see a position where the secretions can be evacuated, and of course where a constant changing of position every 2 hours needs to be installed and to be taught to the family members and the caretakers of the person with spinal cord injury, and with the proper handling techniques that were explained with the other speakers, the patient can be moved safely. Next. For tetraplegia 6-7C, of course, here we see that in the terms of mobility, we will have an extension and a certain muscle tension that allows that the patient will be able to do extension and then maybe also handling specific phases of a wheelchair pushing. This early rehabilitation is also accompanied with being able to transfer the patient from his wheelchair to another seat. And of course, here he needs maybe to have a support with pushing gloves, but also to be stable in his manual wheelchair. Next. And as I explained here, the transfer is very important with a transfer board where the patient can be transferred from a bed to his wheelchair or to a toilet chair. And of course, there are specific steps that need to be undertaken to make it as safe as possible. And I think most of the therapists are quite familiar with how this can be done in the most safe way. Next. Important on terms of function of the upper limb and the arms more specifically, when we have high lesions, we know that you can prepare the patient so that his grip in terms of his hands can be rehabilitated. It's called a tenodesis grip. And this tenodesis grip is going to create with, thanks to his remaining extension of the wrist, there will be a kind of passive flexion of the fingers. And that passive flexion of the fingers will be able to grasp specific objects. And this grasping technique can be used for his functional future in terms of activities of daily living and upper limb function. Now, to set up this tenodesis process, there is a careful examination first that needs to be done. There needs to be a preparation by the therapists to prepare this movement and to prepare these different exercises with the patient. And there needs to be also a very temporary positioning of the upper limb and the hand so that these retractions at muscle level for the flexion can be maintained and have tension enough to sustain the grasp of the upper limb. Next. Of course, this leads to very interesting applications for this upper limb if we have assistive technology that helps the patient to grasp objects and objects that can be functional for his daily living activities, such as eating, grooming, and taking care of himself with his upper limbs. Next. The considerations for mobilizing and active self-care have mainly to do in specific settings and where it is needed, where the patient needs to be independent as quick as possible, that he can check the skin by himself. But of course, thanks to specific manipulations and a specific hand function where he can check, for instance, his skin by using a mirror, but also by controlling much better on how he can check for pressure wounds. And as we will see later, looking at how he can prevent himself from pressure ulcers. Next. The wheelchair use, of course, is very important to do this very safely in very safe conditions, meaning that footrests, armrests, a wheelchair needs to have very basic features that can be functional for him, and making sure that the caretaker is also well educated and well informed on how to use that wheelchair correctly. Next. In terms of lower limb paraplegia and supported standing, and here we see already we have other levels of injury, it is important that standing is a very important activity for daily living activities, but it has also very good effects in terms of muscle tone evolution throughout his body, meaning that standing needs to be done also in safe conditions. It can be reproduced at home, but with the right education in terms of the caretakers that can perform this at home. And it is something that therapists need to be constantly teaching to the patient that they are seeing or that they are seeing at the rehab center. But we can also reproduce these activities at home if the caretaker has a good advice and a good education and understanding the benefits of a standing position first, and secondly, to be able to avoid a lot of complications due to resting all the time. Next. The gait training, if it is possible, of course, and if it can be measured and that the potential of gait is there, is important, but of course it needs also to be accompanied with safe equipment such as parallel bars, or reproducing these parallel bars maybe in the home setting of the person. You need to ensure that all the different joints are quite stable, and they need to be accompanied by the specific techniques of the therapist. And very important as well is, of course, to combine this early rehabilitation gait training with wheelchair use, so that for short distances or mobility within the house perimeter is possible maybe by standing, with the proper orthotics that maybe are needed or the calipers that would be needed to sustain a good standing position. But on the other hand, for mid and long-term distances, of course, the wheelchair would be better advised, for a functional or for a community ambulation. Next. Drop foot is a complication that we see very often in of course when patients are being seen after a while in long-term settings. It is important that you can manufacture sometimes with very simple materials to ensure that the dorsiflexion is always maintained, because that dorsiflexion will also allow that the patient in the mid and the long term will still be able to do his walking exercises. Because once that dorsiflexion is not proper anymore, or is not useful anymore, or is not present anymore, there is of course a big risk that he cannot exercise his ambulation that is still remaining in his lower limb functions. Next. Pressure relief, of course, as we have seen and we were explained by the former speakers, is very important in terms of the caretakers when patients need to look at it, and the health workers as well that need to follow up on the skin problems. However, pressure relief itself needs to be thought, needs to be educated to the patient and explained to the caretaker, of course. And here, when we see that pressure relief can also be done already sitting in the wheelchair, just with simple exercises of bending over or bending on the side, so that pressure relief on the seat can be managed. These are also exercises that can be very simply explained in any setting to a patient or his caretaker in order to prevent these skin problems. Next. Cushions are a very important feature. Now we know that cushions worldwide are available in different formats. First, they need to be delivered clearly when a wheelchair is delivered, and not one doesn't go without the other, because we know it leads to a lot of complications in terms of the skin care. But a cushion has a certain shape, and we see that according to these shapes, it creates a depression, of course, in all the different levels of the seat. And when a cushion is purchased, we should see that, for the assistive technology, that this cushion is of good quality first. And secondly, it is very important that the cushion needs to be delivered together with the wheelchair to have an optimal function of preventing the pressure ulcers. Next. The cover is also important in terms of the hygiene, because that cover also can be, of course, then taken off for being washed and being maintained. And we know that sometimes in providing the cushions or delivering the cushions, the covers are not always available. So it's very important to maintain and to make sure that cover is also present in the delivery. Yeah. Next. Now, in terms of adaptations, once that the person goes home or goes back home to his environment, we know that when we talk about the thematic of conflict settings, that this environment is not always easy. So there is a minimum of types of adjustments that need to be done in the surroundings, either in the living space where the person is living and going back to. On one hand, there needs to be adaptations in terms of toileting, and being able at least to have very basic sanitary conditions that are accessible, but also being easy to be used by the caretakers, for which the patient needs his help as well. So it means that if you talk about long return back home, it needs to be accompanied also with the necessary information on how to make it accessible at a minimum for a person with spinal cord injury, and to facilitate the care that the caretakers will have to provide to that person. Next. Now, my last part will go more about concrete issues, because I think we have seen different introductions who are very structured on how spinal cord injury should be managed. Now, the reality is that in recent conflicts, in recent settings, we saw that this reality is not always present when we think about rehabilitation centers that are not accessible financially first, or even functionally, or the waiting lists are too long for people to have access to that specialized care. The reality is that in conflict settings, we see the patients in the community, and they will not be surrounded by all the professionals, that are necessary to have a very decent rehabilitation. So what would be my advice for a therapist to be confronted with somebody who is in displacement? The first thing would be needed is to see what is the status of that patient. And we have seen the different tools of classification of SCI. Well, the MAXT scale is maybe a tool that is much more shorter to administer, and you will have a much more quicker knowledge on what is the classification, or is the classification still confirmed for that patient at the moment that you are seeing him. The second point is to know what is his functional status. The functional status means you have to measure what bladder and bowel capacity he has, what mobility he has still there, what is his level of independence in terms of ADLs. And for this, the SCIM scale is a very good tool that can be administered, because you can ask it to the patient, you can ask him to perform certain movements, and then you will have a kind of scoring that gives him a kind of functional level. And from that functional level, you will be able to plan and to look at what type of exercises he would need. A third examination that is also very, very important is what is his risks of complication that he has. Again, when you see a patient 3 years, 4 years after his injury in displacement, of course, you know that there is a whole set of risks that he is facing. Of course, we can list them very easily, but you will have to, maybe thanks to a questionnaire, which is the SCI-SCS, you could go to all these different risks, and you can rate each risk, because the patient will say if it is a problem for him, or you can observe it on the patient if the risk or the complaint is there. And from there, you're going to prioritize what would be the priorities that these persons need before they go home, and the risks of complications that they face before that they will go home after their session, after the rehabilitation center, or after the displacement. Yeah. Next. Once these measures are performed, you will confirm that functional status. You can select what will be the main functional priorities for the patient. Well, not only maybe for the patient, but also looking at how the caretaker can find the best options to assist the patient, so that he knows when he's going back in displacement, or when he's going back to a home that is maybe not prepared, on how that caretaker is well informed about all the different function levels that the patient still has, and the functions that the caretaker will have to assist to. And of course, with the risk scale, you will be able to look at what priorities can be addressed, maybe that don't need to be addressed directly, but maybe that consultations or follow-up would be needed maybe in 1 or 2 months, according to the different risks of complications that you will discover when you are doing the risk scale. Next. Once that care is delivered, we know all the different advices, that in terms of therapy, that are needed in terms of recovering the function and assisting the function. But basic mobility advice and safe bedside handling and transfers, moving around with safe, accessible perimeter at the displacement dwelling is very important. You need to have preventive information for the main complications that are observed and risking to become more critical, during the displacement episode. And of course, there is the whole range of personal care by teaching the safe use of assistive technology. And here you will see there is a list of specific assistive technology that should always be available when we are working in emergencies. And I think the basic lists that have been developed here, and I think that this is an example for Ukraine. I think that these packages are already a very good basic approach to restore the minimum mobility for a person with spinal cord injury, ranging from a good wheelchair, a transfer board, but also a toilet chair, and other devices in terms of management of bladder and bowel that will need to be there for the patient before he's going home. Next. The examples that I could witness when working in these specific settings were that Skin care was always a point that came out in the terms of advices to provide to the patients, knowing the location of it, teaching the seat relief in the wheelchair, and providing, of course, the specific assistive technology to work on pressure relief. The second issue was, of course, the bladder and the bowel, and here you would need to give specific information to the patient and the caretaker on how they can handle it better, but also looking at how the bladder and bowel administration can be facilitated with help of the assistive technology in terms of toilet chair or specific mattresses or specific equipment that is needed. Of course, the mobility and the handling also needs always to be reviewed and updated together with the capacity that the patient still has in terms of his functional status, but also on how the caretaker is able to understand better what the patient is able to do to keep him still in an active lifestyle. And that goes from the different transfers, but also assisting him in his daily living activities. Next. Acute complications and needed referrals, well, they will be mainly, with the tool that was used in terms of the secondary complications questionnaire, you could maybe prioritize, all the different complications, that you have been seeing, why, the acute risk in terms of infections, either it's skin infection because of pressure ulcer or bladder and bowel infections. You will need then to make a list in terms of what kind of referral would be a priority, to get medical advice in these specific settings so that the patients could have the best care possible. The other issues are mainly having to do with pain, and here also we know that pain specialists can opt this or giving specific medication to have a better quality of life for the patient in terms of his mobility. And of course, the last one is very important, is that provision of the mobility products in emergencies that I mentioned earlier on, that need to be available and well explained to the caretaker and the patient before that he's going home to another setting. Next. As a conclusion, we know that the essential therapy considerations for the local rehabilitation workforce, they have to do with strategies of capacity building for preparedness as well for the professionals and the therapy professionals. And that means you need to have tools that can make a quick assessment of the needs of the patient, tools that measure a functional recovery status and the identification of that functional status of the patient so that the exercises and the advices can be well prepared according to the level of functional status. And of course, there needs to be a provision of assistive products that can assist the daily living activities of the patient and his caretakers as well. So this is where my talk ends here, and I will leave now the floor to my other colleagues in the panel. Thank you very much.
Excellent. And I think, Joe, you're on here now too. So
Yes.
yeah.
Well, thank you, Eric. And I think just to conclude, it is critical for spinal cord injury care to be delivered as a multidisciplinary team, just because of the different body systems that are involved and the secondary complications that, if they are not managed, can be catastrophic for an individual. And the planning for discharge is important to be done as soon as somebody enters any kind of rehabilitation. So to think of where they are going and what are the essential pieces of equipment for discharge. Giving an example, if somebody is going into tented accommodation with a no or unstable electricity supply, air mattresses are obviously not going to be appropriate. So just to conclude, we've got some resources to highlight for you. The Early Rehab in Conflict has a chapter on spinal cord injury. We've also got the minimum standards for spinal cord injury, the WHO documents there, and for medical teams. In addition, some of the slides that Eric has presented are drawn from the training in assistive products, the TAP resources. These are freely available through the WHO, the World Health Organization website. And I've got some excellent training around use of any assistive devices and transfer techniques. We're going to spend there's also some free online training through the ISCOS website, which is the eLearn Spinal Cord Injury. That has training for specific healthcare professionals, whether you're a doctor, a peer educator, a nurse, a therapist, so within different specific professions, and set out on a modular basis with a certificate available for completion. And then with the Asia Foundation, the one there, provides comprehensive training in the classification of spinal cord injury. And I've put in, I think, in the Q&A area, if there are any healthcare workers from Gaza or Lebanon, they can access that training at no cost by emailing the Asia Foundation for that. As part of that, there's also an online calculator, so you can feed in your results from completing that, and that will give you the neurological level of injury for an individual. This takes us very well into the questions, and I'm going to start off with a question we've got about communicating prognosis. So Dr. El-Malik, we've got a question here mentioning how difficult it can be to understand what prognosis is, if somebody may be changing from an Asia A to an Asia B over time, and when should a clinician accurately estimate and communicate prognosis to patients?
Thank you, Joe. Thank you so much, everyone. So, look, it's not an easy path, but what we need to make sure that, number one, we provide the correct information. So we should always try to, give realistic expectation to the patient. So it's a gradual conversation. So what we always try to do is to differentiate between hope and expectation. So we always hope that the patient will regain the maximum recovery, but there is our expectation that he might not. So if you do it this way, I think you will get away from the embarrassment between, you want to be kind and nice to the family and the patient, but also you want to provide the appropriate factual information to the patient. But also, you always say that, and to answer your question, the recovery is not, we can predict, but we cannot be certain of the recovery. But we predict this patient, for example, in 6 weeks, 3 months, may be able to do this. This is why, according to the available data, for example, spinal cord injury, high thoracic will be able to use wheelchair, and incomplete will be able to be independent using it, but you provide this based on the factual fact you have, but also you say that, however, there might be patients who might recover faster, might go further than that, or might not be. And recovery, as I always explain to my patients, is not steady line. So it's go like that. So they recover today, tomorrow, then they be impacted by fatigue, by anything like if they got infection, anything that can delay their progress as well. So you need to be, to conclude, I think you need to be factual, but also you need to provide hope to the patient.
Thank you for that. One of the other things we've certainly found research-wise is that an INSCI carried out after 30 days gives a more accurate prognosis than one done in the first couple of days. We've also got a question about spinal cord injury bowel management. The difference, is there any difference for paediatric or adolescents in terms of bowel and bladder management? Colleen, are you happy to answer that?
Sure. In general, there is no difference other than in terms of the size, other than very young children, generally less than 2 years of age, do not need a catheterization because they have not yet got developed sphincters. And for any of you that have had infants and children, you know they are already incontinent. So generally, though, above age 2, you still have the same approaches for the bowel and bladder management.
Thank you. We've got a question about positioning and pressure relief, the practical accepted standard in conflict settings. So pressure injury is obviously a high risk in conflict settings. And if somebody is mobilizing in a wheelchair, a pressure relief cushion is an essential component. We would then recommend that somebody carries out pressure relief for 2 minutes every hour. So that might be through a forward leaning technique or a side leaning technique. But I would check as a therapist by putting my hands under the ischio to check that they are properly offset, that they are de-weighted, to make sure that that is effective. If somebody is in lying, whether they are on an air or a foam mattress, it is important that they have a regular position change through side lying or potentially prone if they are able to cope with that. And there are some great images on the assistive training, the TAP resources to support that. Okay, I think have we got time for one question, one last question in terms of feeding. Yep.
Joe, we can if people need to drop off at the end of the time here, the 5 of us are willing to continue to answer the questions, and that will then be available in the recording that will be made. And as well, the leadership for these webinars will be having some discussions about, there's a lot of questions about certificates. And so there will be a follow-up in order to answer that once the organizing leadership has looked into this.
Great. So we had a question, I think, Erica, you were happy to answer, about people who were interested in working in conflict situations. Erica, are you on the call to be able to answer that?
I am on the call. I did answer it in text, but I'm happy to cover that again. Thanks, Joe. Great if people are interested. The rehabilitation in emergencies workforce always needs bolstering. Probably the most straightforward ways would be to look at the websites of some of the major organisations that provide rehabilitation in emergencies. Most commonly, these are Médecins Sans Frontières, or MSF, Doctors Without Borders, the International Committee of the Red Cross, ICRC, and Humanity and Inclusion, or HI. If you go to their websites, you can find information about how to join those organisations and available positions. You could also consider becoming part of an emergency medical team. Your your governments may have emergency medical teams, so I would suggest trying to find out about that and see if you can become a member, and definitely ask them if they have rehabilitation capabilities, and if not, then ask them why not. But also UK Med, they are a team that's an NGO that has an emergency medical team, including a specialised team for rehabilitation. So they are also an organisation you could look at. And I know that if you're a spinal specialist, there is an organisation called NORWAC that also has a rehabilitation specialised care team for emergency medical teams. So that information is in the Q&A under the answered section.
Thank you, Erica. We've got a question about alternative feeding to be considered in the case of spinal cord injury or only in the case of comorbidities. and about swallowing and positioning during feeding. Colleen, are you happy to answer that one?
Sure. Oftentimes, it first is to identify what the reason for the swallowing impairment is, and then how you're going to manage that based on the cause. For many patients with cervical injuries who may be in a collar or may have had some swelling or involvement of their esophagus from the trauma or from the post-operative, or they're in a fixation, they can't easily do the chin tuck and position. So you want to avoid hyperextension of the neck because it's harder to swallow. See if you can allow to be in a slightly chin tucked position and upright for feeding, using smaller amounts, single textures, and generally of a thickened, like a honey or nectar or pudding thickness, uh, can help facilitate the swallow. Even you can thicken liquids, even with a bit of cornstarch or sometimes tapioca, and that can help as well with the swallowing.
Thank you. We've got a question, Firaz, for you about rehab strategies available to improve bowel control in an individual with an areflexic bowel.
The key thing to consider here is we need to wait till the patient is recovering from their spinal shock, and that really will give us an indicator in terms of to use the remaining of the sphincters, I mean, function. And based on that, that will be able to enable us to have a bowel regime effectively, whether that will be managed daily or managed every other day, based really on the results that we are having, as well as documenting the result. I think is quite important and essential in terms of bowel management, because that will give us an indicator in terms of what pathway we want to choose for that patient, whether that's daily or alternate days for bowel management.
Thank you. We've got a question about tilt table standing for a tetraplegia patient. Eric, do you want to answer that, or would you like me to?
No, Joe, you go ahead. You're closer to the tilt tables than me.
Okay. So standing, we would say, is desirable for a spinal cord individual with spinal cord injury, but not essential. There are other ways to maintain their joint range of movement. And the evidence is that it's not necessarily very effective to maintain bone density. One of the considerations before standing is that somebody is able to tolerate sitting out, because it is a much bigger challenge for their blood pressure and for orthostatic hypotension. So if you were to look at standing an individual with tetraplegia for the first time, the prerequisites would be that they are able to tolerate sitting out for a few hours, potentially that they have an abdominal binder in situ, and that you have some options of monitoring their blood pressure, because you're trying to mitigate against the blood pressure dropping very low. You would go up gradually and monitor somebody's symptoms. You may do that by looking and are they able to keep talking to you, or you may do that by continuous blood pressure monitoring. And if somebody is feeling unwell, you'd lie them back flat. But if you're able to, so you'd aim to achieve an upright standing regime with a tilt table, and then see if it's possible to progress onto a standing frame with chest, pelvic and knee support involved in that, if that is available. Okay, we've got a question about, in physiotherapy practice, the appropriate time to introduce and address patients' sexual activity and sexual function during rehab, and gender. I don't know if maybe if Colleen and Dr. Al-Malik want to start off with answering that.
Sure, I'm happy to. It's an area that I do feel quite strongly that this is it's a very sensitive area and a very important important area of a person's quality of life, their identity, and in a lot of times their well-being and emotional adjustment to their injury. It's the entire team's role to participate in discussing sexual health concerns. Very importantly, though, before those discussions take place, is that the team is aware of and understands the injury level and severity by doing the INSCI examination, because that will help guide how and what you tell that individual about what is biologically possible. And that becomes very important, particularly with male patients, as it pertains to their sexual function, as well as their ability and how they would be able to have children. So once that information is known, it's the member of the team who is the most comfortable and knowledgeable about that area. Typically, it's the physician or the nurse who may address those questions. But other team members will be very important. The psychology support needed for the emotional adjustments, which includes body image. The occupational therapist helps with positioning devices that may be required. The physiotherapist may help with regards to mobility options that are required for some activities. And so the speech and language pathologist in terms of means of communication. So it really is a team approach. I think the important thing too is for every individual, you need to ask permission to discuss the topic. So it's when that individual becomes ready and they give you permission to the health professional to start having that conversation.
Yeah, and I will just add, it's very important to talk to both genders. Yeah, there is a lot of focus, I think, on the male needs, but of course we need to look also at the issue of the female position in this infertility and what is expected, of course. Yeah.
Can I also mention something in relation to patient education and sexuality? Because we have this is one of our major topic, and therefore we educate our patients about sexuality and becoming a father or becoming a mother, and motherhood and so on. This is really quite important and essential, and we tend to do that pre-discharge from the spinal units, and we offer them all the facilities that we can, in terms of either medication or therapy, etc., within safe environment.
I
Thank
just
you.
want to add something, sorry, Joe. So experience in our center, we touch on the sexuality topic the first time the consultant meet the patient. So the first point that the registrar or the trainee will see the patient, admit them, and then the consultant, when they come in the ward round, the first time they see them. So after everyone leaves, they come to the patient and say, "Look, if you want to talk about this, I'm happy to provide information. I'm happy to come back to you in the times that suit you." And you can invite, whoever you want. If you have a partner, if you have, anyone you want to invite, you can invite. And we talk during our session, we talk about, everything about sexuality, about relationship, intimacy, and sexual function, and also fertility. And sometimes we refer them to the sexual counseling as well. So this is, I think there was a question about how to approach it. So this is how we approach it in our center. So which actually, everyone has said the same thing, but we approach it in this way. Thank you.
I think that's very helpful. Thank you, Dr. Malik. So it's giving a patient understanding that it's something that can be discussed, and then when they're ready to, that there's availability to ask those questions. We've now got a question about us as health care professionals. Sometimes it can be quite heavy emotionally to support individuals with navigating spinal cord injury, particularly if you're not surrounded by a multidisciplinary team. And how can we manage, I suppose, our own well-being through that? One really strong option for supporting individuals with spinal cord injury is peer support, that we have not talked in much depth today. So other individuals who are managing to live well with their spinal cord injury and have a little bit further along in their journey is often a really useful way to support individuals and to role model that, which can take some of the burden, I think, sometimes off the healthcare professionals, and be a really strong asset to any team. I think for all of us as healthcare professionals, self-care is important. So having some time away from the workplace and knowing what is restorative, often being outside, but making sure that you have people, colleagues that you can talk to about the things that are difficult and challenging, which we all have, and that you're able to take some time to look after yourself. Does anyone else want to add to that? Yeah. All right.
I'd just say, Joe, we've got a hard stop in 2 minutes, so we.
Right. Okay. We've got
I
a
think
question.
Joe, just before you go, I think you have mentioned something very important. Caring for a spinal cord injury or any neurological deficit, in all the rehabilitation is a multidisciplinary team approach. There is not one person, it's not one team. So we need to be aware of that. We need to work together. We need to help each other. And in our center, and I'm sure this is in all the centers. So we have always an early family meeting. Family meeting means that, explain to the patient and this family what the nature of the injury, and then you set, goals and stuff like that. And then you have mid-term or mid-stay family meeting, and then you might need another discount family meeting. It's very important to get the patient involved, is patient-centered care, and patient to take lead of that, and also patient to take lead in his care for himself. So this is what I wanted to add. Thank you.
Great. Okay, I think we've responded to the questions that are there. This is very much an overview today, so not fully in depth, but thank everybody who has contributed as a presenter, and also to everybody who has joined the webinar. We've enjoyed sharing our knowledge, and please do have a look at the resources we've signposted you to for further help. Thank you.
Thank you.